We're going to just do a sort of a pictorial review of how we take IVC filters out that are a little bit more difficult than standard sheath and snare techniques. And anybody that's ever been in one of these cases probably feels a little bit like my son did, kind of like a noose around your neck. They can be extraordinarily challenging. There's a pucker factor associated with some of these cases that is unlike many other cases we do. And I will tell you that in many of these cases, there's also a point of no return. So you want to make sure that you've mapped out the whole procedure before you even step into the room. So with that, this is the first Vena cavogram, and many of you have seen this before. This doesn't look like a terribly tilted filter, but you can see that there is this radio opaque or radio dense thing encasing the hook, and this filter is actually tilted in the anterior posterior plane, and this is a fibrin cap. And if you take a standard snare down to take this filter out, it's not going to work. So there's a lot of different ways to do it. The first way that we're going to talk about is using a loop wire technique. Some people have called it the hangman, but it is actually just a loop wire technique. And what you do is a reverse curve catheter, like a SOS, a VS1, or whatever else you want, and you engage the tissue plane between the filter hook and, the filter apex and the cable wall. And once you get that in there, you send a hydrophilic wire up, you snare it, and then you take it out. You need at least a 12 French sheath to do this, considering that your catheter is about 5 French. So these are a couple videos to show you how you do it. In this case, you can see that we're not through the filter struts. We're actually engaging that radiolucent fibrin cap, and then you send your wire up here, and you snare it, and then once you have snared and externalized it, that's your sling to take the filter out. And these, all these pictures we're using a 16 French sheath. Another sort of graphic representation, you can see that it doesn't look like you have anything, but you actually do, and you'll feel traction as you're trying to retrieve it. Another technique which was pioneered at Deepak's home institution, which is use of the rigid endobronchial forceps. Again, this is a tilted filter. It doesn't look terribly tilted on this Vena cavogram, but there's exuberant fibrin cap formation around the filter apex. And in this case, you can use what we like to use as the jaws of life. And Deepak's Bill and Scott really pioneered this technique, using at least a 12 French sheath, but up to 16, 18, or larger if needed. I like to use this particular set of forceps. There's 2 other types. This one has a lot of body to it. One thing to remember, and we talked about this a little bit yesterday, patients feel really uncomfortable when you do this. And that level of discomfort is directly proportional to the amount of bend you have on the forcep. It causes a ton of cable distension, and they can feel like back pain, a lot of belly pain. So if you anticipate using rigid endobronchial forceps, I would strongly advocate getting anesthesia support. Maybe not general anesthesia, but at least monitored anesthesia care. So a graphical representation of what this looks like. Again, there's a fibrin cap, and you can use this to not only dissect that cap off, but you can also use it to just grab the filter apex and take the filter out. A couple videos. It's important not to just bite down blindly. I have the jaws open, but I'm turning back and forth to see what part of the filter I have. And once I'm convinced I have the metal, and you'll often feel metal on metal, then slowly rotate it back in so it's all in line, and you can sheath the filter easily. It's important not to sheath the filter like this because your lines aren't straight, right? The apex is going to be outside, and you're going to be grabbing the neck instead of the very top of the filter. Graphical representation, again, here's what a fibrin cap typically looks like. And I wouldn't be at Sinai if I didn't show a filter inversion case, and this is an homage to the technique that they initially described. This is a patient that was sent to me with a Denali filter. The filter apex is through the cable wall right at the junction of the left renal vein and the IVC, and it in fact was fractured as well. So one thing to note is that the CT did not show the fracture, so in that 2 months between the CT and when they're on my table, the fracture occurred. And I completely agree, take spot films before you touch it, because you want to document exactly how it was and exactly how you left it. So we go down, and you'll see that we take that strut out first. I strongly advocate, if it's loose struts, you want to take those out before you take the main filter out, because you can end up embolizing those struts, as I'll show you in a later case, while you're working. Then your Vena cavogram that shows you indeed the CT was correct, that you have complete protrusion of the filter apex through the cable wall. And here in this video you can see what we did. So you have to get kind of as much of the filter as you can with the jaws, and then this is an equal and opposite pull and push with the sheath, and then you successfully invert it. What's important to do in these cases is not only to do a Vena cavogram, but also a selective venogram, in this case a left renal venogram. And you can see the pocket right here where the filter apex is going through, but there's no active extravasation here. we're going to move on to a technique that we'll initially describe and we use to a large degree too, which is the use of the excimer laser sheath. And this is particularly useful in patients that have filters with closed cell design. These filters tend to get struck right where those loops meet the primary struts, and that's where you encounter your maximum resistance. You have this big ugly gray box in your room. It's plugged into a 220 outlet. This is meant, it's on label for removing cardiac pacemaker leads. It's actually completely off label for filter retrieval. But the interesting thing, at least in my opinion, is that filter retrieval with the laser sheath is safer than what it was actually designed for, which is removing embedded cardiac pacemaker leads in the subclavian vein. So what you do here, and that's not actually what the laser looks like. This is just the ring of fire to show you that the sheath is plugged in, but the laser is an ultraviolet white laser. And you take it down to the point of maximum resistance. You have to have good tension. The laser will not help you get an embedded filter apex. It's to help you peel embedded struts off of the cable wall. Once you go down, you feel the maximum resistance. You step on the pedal, you hear this awful noise, and it cuts right through the filter, and you take it out. So the entire idea being here that you reduce the amount of effort and tension that you impart to the vena cava wall by using the excimer laser sheath to provide assistance. I have a video of it. It's not particularly illuminating. It just shows that we got there, and you don't hear the sound effects. I'll try and do that for the next talk, and you're successfully able to collapse it. And these are exactly where these filters get stuck. These are these adherent fibrin-rich thrombi. I mean, they're not really acute at all. They're chronic, but this is what's causing that filter to remain stuck in the vena cava. The last two cases are going to be sort of examinations of how you really, for these most complex cases, have to use multiple techniques. It's not just going to be one. So this is a patient that has an Optese filter, got a stent from Maid Thurner. You could argue that it's a little bit short from our outside a hospital, and this filling defect within the caudal vena cava right at the hook of the Optese, and you wonder, well, what is that? Is that adherent thrombi? And certainly that's what we thought it was. The filter's fractured. These can be extraordinarily difficult to take out, especially when they're fractured, because you no longer have a closed ring. Cavogram confirms that there is this filling defect here. So we have to use a forceps to engage it and get it inside the sheath, and then we laser it, and this is what we've typically seen with these devices, is that the laser gets to a point but is no longer able to advance, and you can see that the filter fractures have remained embedded in the cable wall. So frequently with these types of filters, you need to get a looped wire through the top and then also laser it from the top and retrieve the filter. So we have a couple pieces left. I would strongly advocate at least trying to go after these pieces. You need to see where they are. IVUS can be very helpful for these as well as multiplanar cavography. So we pulled those pieces out, and then we also wondered, well, what exactly is this cylinder? We didn't really know. So we pulled it out, and it was a balloon that had been left behind by the physician that previously tried to retrieve the filter and did not tell the patient that they had abandoned endotrash inside the vena cava. One of our more spectacular cases. So we were able to get that balloon out, and it looks pretty nice afterwards. This is another case, another Optese, or sorry, I believe, yes, this is an Optese filter, and you can see that this is already fractured before we even touch it. One of the things that I practice is if it's fractured and you know it's fractured, I get a gated cardiac CT. You want to see if there's anything in the heart, and it can be hard on x-ray, it can be really hard on live fluoro because the heart is obviously beating, so I get a gated cardiac CT. It's just simpler to do it that way. And in fact, this patient has recurrent arrhythmia with the strut embedded in the tricuspid valve. They're going to go on pump anyway to take that strut out. We're tasked with taking the filter out before they go to the OR the following day. So again, you see a fractured filter, sort of a familiar case, very similar to what we did before. In the previous case, lots of fractured struts. You want to take your time making sure you get these struts out, so using a combination of sheets and snares. And we always consent these patients that you may lose a strut, and in fact we did. And here on this initial image, it looks like it's in the heart, but it actually, you do an oblique and you see that it's not in the heart, it's in the pulmonary artery. So we go after it, selectively catheterize the left pulmonary artery, do an angiogram, and after the angiogram, it's gone. The strut is no longer there. It has moved. So I thought, well, maybe it moved into the lower lung base. I'm not sure, but being an IR, we have the benefit of having cone beam CT. So here we find it. It's like, okay, that's interesting. Maybe it's in the base of the left lung, and cone beam CT shows where is it? That's in the abdominal aorta. So I had reflux with the hand run. This is not an injector run. The modest 20, 30 PSI get out of my hand. I'd reflux this from the pulmonary artery back in through the main pulmonary artery into the RV through an unknown secundum defect in the left side and then down into the aorta, not into the carotid, thankfully. So lots of ways you can find yourself in trouble with these cases. So you got arterial access, pulled that out of the aorta, and luckily she's doing fine. So hopefully I've shown you that advanced techniques can change a game. You need to know your tools. You need to know their strengths and their weaknesses. For the most complex cases, one tool may not be enough. And if this is not something you do frequently, make it a team sport. Don't get in over your head. Call a partner, especially one, hopefully if they're more experienced than you are, or if you're the experienced one, lend help to the less experienced partner, and make it a team sport to get the filter out. Thanks.